I have tried to show how an implant can be bent. See, the implant when was inserted, it was directly touching the nasal floor. Okay. Or if it is a traumatic case, first one is a healed socket, other one is a traumatic case where an extraction has been done. And then from the palatal aspect, you approach deeper inside the nasal floor, because we have to understand that till that point where the tooth is, that is the alveolar bone. Okay, after that there is basal bone, and there is above that there is dense cortical bone. So you'll always try to engage your implants into two cortex. Okay, those two cortexes can be either the buccal wall and the lingual wall of the bone. Again, you are reaching one cortex, or it should be the crest, that is your first cortex, and it should be into the basal bone or below it, which is the second cortex. The same has been done, and the implant has been bent. Okay. So yeah, this is a very exciting image. This image itself entails corticobasal implantology. We don't have fancy abutments. Okay, we don't have any screw return things. Okay, we have only one property known as isoelasticity, and we are good at bone finding. We are brothers and sisters of Phil, who is at University of Dundee. Okay, and you see this coconut tree. The roots of this coconut tree are so far away from the load bearing or load area. Okay. Similarly, and still the coconut tree is alive and it's functioning. Every year the fruits happen. Okay, people like me will go and sit there. Okay, okay. But again, see, the implant has been bent, occlusal loads have been applied. Okay, so yeah, just keep this image in your mind, and whenever you are doing corticobasal implantology, just remember this coconut tree. Your implant should look like a coconut tree. If it is out of alignment, you should torque the ratchet, you should bend the implant and bring it in the arch. You can bend it 30 to 45 degrees, no worries. Okay. So yeah, this you see, this actually is the CBCT of one of my patients. The surgery was supposed to be done yesterday, but due to heavy rains, the surgery was postponed. Yeah, but anyways, just look at that schematic diagram. Wherever, brothers and sisters, wherever you see green areas, those are the areas you are supposed to place implants. You will place implants. Okay. So that means in the lower arch, we have the very dense cortical bone. Okay. So in that green box, you are going to place 4 to 5, maybe 6 implants. Again, people are apprehensive and anxious about the mental nerve region. I just want to tell you that, yeah, mental nerve is a concern, but if it is a fresh extraction socket, mental nerve is not your concern. Why I'm saying is that because once you extract tooth, a premolar, suppose you are extracting the first or the second premolar, and we know by anatomy that the mental nerve is emerging at the apices of the second and first premolar, maybe below the second premolar or in between them. Okay. So what you need to do is you need to take a wider diameter implant, 5.5 or 7, something like that. And once you have extracted it, you have the tooth in your hand, you take a probe or a scale, you measure the length of the root of the premolar which you have extracted, okay, and you insert a wider diameter of corresponding length. You will never injure the mental nerve. In case, what is happening that it's a healed socket, okay, then we have to think otherwise. That is when we go to the second molar or the distal molar area, in case where long-term edentulosum is existing. Okay, for say in this case where I have attached the CBCT of my patient. Okay, you see her premolar is standing till now. Okay, but there is no molar, nothing, and there is no bone in the maxilla at all. She is a case of trauma-induced osteolysis. Means she was in a village, and those bore wells where we pump water. Okay, and that washer of that pump slipped and it hit her face, and after that she started losing her teeth one by one. 2 weeks ago when she came to me, so this was the scenario. And yeah, we'll rehabilitate it. I hope I'll be able to show you this case later on. So yeah, and in the maxillary area, if you see, we have the canine eminence area, and we have the pterygoid area. You see broad purple pinkish arrows. Okay, you can always distribute. You can always distribute your implants accordingly so that the inter-implant distance is not very excessive. In for say in this patient's case, okay, if I insert an implant, I don't have bone beyond 1/4 and 2/4 area. That means I have to do 1/4 and 2/4 in a angulated manner so that I can cover it from the nasal floor as distal as possible, and then again place two pterygoids so that I can minimize uh, the inter-implant distance. The same has been I have been tried to depict with broad purple arrows in the picture. Okay. Yeah. So coming upon to the basic implant design. Okay. So the basic implant design, bone anchor, what they have is various series, where is pros, V-pros, vampires, zygoma, etc. So these are all. This particular is the compressive implant. Okay, we can see the rough surface.